All right, here we are again with another Basically EMS. Got Wade today with me. The crew.
The crew.
The crew's here.
Terrible two.
We can come up with something.
Yeah,
better.
something clever.
Yeah, comments. Leave us a better nickname than the Terrible Two.
Oh, that's gonna get mean.
Can't be any more mean than we are to each other off mic.
That's fair.
So, yeah, bring it. We want to hear it. Bring it. Today we're going to be doing another differentials episode. So today we're going to be talking about differentials for GI issues. So I want to make that distinction of GI issues, not like abdominal pain, because abdominal pain could be like a gynecological emergency or something. So we're specifically just going to be talking about GI issues.
Right. Anything in that peritoneal cavity can be pretty broad.
Yeah, and I know for me a lot of the time it's just kind of like a magical, mystical thing of like, there's a lot that goes on. I'm not going to dig too deep into it, but it's still good to have kind of a broad understanding of what could be going, because some of these are life-threatening that you need to be able to recognize.
Right, and that's the big one. Can you identify life threat or not, right? And frankly, I'm just going to kind of bluntly say it. Most of these calls, from our perspective, seem fairly benign just because there's not a lot we can do, right? These things are the type of complaints that escalate when they get into the hospital. Yeah. Obviously barring shock signs and some of the stuff we'll talk about. Yeah.
So before we jump into specific, let's talk about just kind of general assessment for patients with complaints we think might be stemming from the GI. So the easy one to start with is just going to be your basic OPQRST. So I know a lot of EMT programs teach OPQRST as like a real like sample OPQRST you should do on every patient. I disagree. OPQRST doesn't fit for like a respiratory patient, but it fits for anything that has some sort of pain. Right. And so a lot of the time with GI issues, you'll have some sort of pain. So OPQRST, especially like radiation region, can be really important when we're talking about GI issues.
As well as onset. I mean, and I'm stickler with severity typically, especially with GI pain. I've ran into a lot of calls where it's like, oh, my stomach's killing me, but they're sitting there chilling, eating a bag of chips, you know, and it's like, well, what's your pain 0 to 10? It's at an 11. I don't believe you, right? And like, not to say I don't believe you, but it's one of those of like, I'm kind of chalking this down a couple steps in severity in my head.
Yeah, pain tolerances are different for people. So maybe they are feeling in their mind a very severe pain. But from when we've seen like fetal position, can't move with a heart rate of 130 just due to pain versus sitting back eating some chips, watching their stories on the TV.
Yeah, got a tummy ache.
Yeah, that's a little bit different.
Yep.
Palpation of the abdomen is going to be really important for these, right? Because there are some specific things like guarding, point tenderness, things that we're going to find only by palpation. So this is a patient type you really should be getting your hands on. Make sure you're comfortable, the 4 quadrants and being able to know. We start opposite the quadrant that has pain if they're complaining of something in a specific quadrant, just know how to palpate appropriately.
Yeah, as an example of that one, because I actually had a couple students asking this question the other day. If it's like, for example, lower right pain, which hopefully the lower right, that's our appendix. That's the big one that there's a few organs we got to be really aware of. But if it's lower right, start lower left and work your way around. And then end with pain, because if you start with where it hurts, they're going to say ow almost every single time you touch them, and then that does us no good. But once again, that was an example. It's not one of those of like, well, what if the pain's in the lower left? Do I start in the lower left? No, you start adjacent to and work your way back around.
Yeah, kind of clockwise, or like a clock, not clockwise necessarily, but like a clock to get there.
Right. And then important organs to remember: upper right quadrant, liver; upper left quadrant, spleen; lower right is going to be the appendix there. Not a lot of lower left. That's more descending colon. So we don't run into that stuff necessarily unless it's something like a block, which we'll talk about. But those are the big ones. And maybe even like pancreas, which kind of stretches between both of the upper quadrants. So, that's where history is going to help solve this mystery, especially medically based. If it's someone who's like, oh, I'm an alcoholic, I'm a known drinker, I'm having this really severe upper GI pain. Okay, that's where we can start leaning into pancreatitis and that kind of thing. But your history and your assessment is going to carry you through these.
Yeah, we don't have the tools, so it's all just basic history taking and physical assessment is all we can really do. We can't just go pull blood and scan or do anything like that. So.
Yep. Be as good at the hands-on stuff as you can, because that's our bread and butter.
Nausea, vomiting, diarrhea is going to be an important one to ask patients about. And when you're new, this might be really uncomfortable to like, tell me about your bowel habits and I guarantee even if it's like, a 22-year-old of the different gender than you, right? Like that maybe you would be really uncomfortable, like similar ages, different genders. Like I remember being a new EMT, 27 or whatever. And if it was like a 25-year-old woman, it was really awkward to ask about those kind of stuff.
Right.
If it's an actual medical emergency, they don't care, right?
No.
They're going to talk about their poop and whatever without an issue because they understand you're there just to treat them. So it's not an awkward conversation, but it might be at first.
Yeah, it's something that comes with comfort, over time. That's an experience thing. I will say the diarrhea thing is a great question to ask when you're being filmed because it really cuts them off real quick. I had one patient, mid-teens gentleman, abdominal pain, diarrhea, and so he's back the ambulance Snapchatting, and then it's just, how long you been having diarrhia? Puts his video down. It's just, bro. It's a good one. That's a good way to end it.
That's the way to cut off the live stream, stop the TikToks. Start asking about that.
Oh yeah.
Kind of in the same vein. Back to that vomiting. We need to ask and bowel movements. What do they look like? What are the colors? Is there blood or any bright red? Anything like that. When we're asking about nausea, vomiting, diarrhea, be specific. What does it look like? Does it smell different than you would expect? Those kind of things. Be specific.
Yeah, and if you have a chance to look at it, no one loves looking at poop or vomit, but it can give you some answers real quick.
Yeah. Hospital doesn't want you to take it with them.
Yeah, don't.
But if you can look and get an idea, it's really helpful.
Yeah, for sure. And also one thing too is that remember nausea, vomiting, even diarrhea more so, or less so, but nausea, vomiting can be a lot of things, right? So don't put a lot of eggs in that basket of like, oh, it's nausea, vomiting, it's GI. Not necessarily, right?
Yeah.
But it does help our case if you're thinking abdominal.
Yeah, for sure. Yeah, if you look on a list of differentials for most things, nausea, vomiting is pretty high on chest pain, on all sorts of things. So don't just fall into that trap. Belching, flatulence can be something as well. Like, have you been burping a lot? Have you been farting a lot or not farting? Like, have you not been able to pass gas? That could be a bowel obstruction or something, right?
Yeah.
So it's not a bad idea to ask about those things just to get an idea. Bowel habits and urination as well. How's all the factory equipment working? Like everything been moving like it should, or has it not been moving?
Right. And this is another one too, where your patient may have something like an ostomy bag, right? And so like take a look at the ostomy bag, or even urine if they have a catheter. That's basically they're giving you the hint, right? They're carrying the bag of pee for you to look at. Take a look at it. Yeah. No one wants to stare at pee. I stand on that again. But got to do what you got to do.
But you'll get to the point where like you'll just know UTIs, which isn't really fitting into here. But yeah, like that. It's amazing if you're suspecting a UTI just to be able to pick up that bag and be like, oh yeah, I can see all the little flakies, nasties in there, and like, yeah, you have a UTI for sure.
Drinking soda. It's got that brown color.
It's gross. Other things to think about, like weight loss, could be a sign of some more chronic issues. And then use of alcohol or NSAIDs are both things you'll see pop up in kind of the pathophys of some of the things we're going to talk about. And so use of alcohol is a big one for a couple different things. And then NSAIDs are not like I get a headache a couple times a week. It's like I'm just chomping down on ibuprofen nonstop. That can lead to some GI issues as well. So another one to kind of think about. And
then NSAID, just if you don't know, non-steroidal inflammatory
drug. Yeah. So, and that's going to be aspirin. Probably the most common ones are aspirin, ibuprofen, and then acetaminophen or Tylenol.
Yeah. Yep.
Most common you're going to see over the counter.
Yeah. I do want to touch on weight loss too, real quick, because there's something to consider, especially in the world of like Ozempic. Is that like nausea, vomiting as a secondary like side effect of those injections is also a very common thing. So that's where if you get the history and you ask, are you taking anything for weight loss? And they're specific, like, oh yeah, I'm taking Ozempic and I'm just nauseous right now. It's like, okay, have you eaten? Like that's a normal thing associated with that. So there's questions you need to ask around that as well.
Yeah, and that's a good thing to know because that's a newer, that's not in your textbooks because that's a newer drug class it's not a newer drug class, but the usage for this drug class is a fairly new thing.
Right.
And it seems like they're pretty prevalent out there. So
yeah, they're and there's all variations now, and so whatever, you just understand the medicine changes, and especially when these fad type treatments are coming out, I would spend time to look into them.
Yeah, and know like Ozempic is a GLP-1. but there's a whole lot of GLP-1s. So knowing
Right.
a little bit beyond that too of like, what is this umbrella, so that, just like Viagra, like you need to know that Viagra is not the only medication that does this thing. So you need
Right.
to have an idea that like there are other medications. Kind of same idea here. Know that they might be taking Wegovy.
Yeah.
And if you ask about Ozempic, they're like, well, I don't take that. But you need to ask like any weight loss drugs like Ozempic or Wegovy, or there's another one I feel like I see.
Trizepatides.
Yeah, like other
sorts of
commercials
things.
for all the time, right?
Yeah. Yep.
But those are prevalent out there now.
Cool. Well, want to dive into GI bleeding?
Yeah, go for it.
Cool. So GI bleeds. I'll kind of read off my little cheat sheet here, and then we'll chat about it. So acute or chronic sign symptom of another disease potential. Reasons for GI bleed can include, but not limited by, esophageal varices, Mallory-Weiss tearing, bowel inflammation, diverticulitis, cancer, and hemorrhoids, things we will chat about a little deeper on a couple of these topics. But the big ones with GI bleed is it going to be upper or lower GI, right? So with upper GI, if you think about, I always kind of draw like an imaginary line, like, okay, if it's in the stomach or like the top portion of the small intestine, this is going to be upper. If it's going to be anything past, that's lower. But the easiest identifier, puke or poop, right? Because if they're puking, that's upper GI. If they're pooping, it's lower GI. So puke or vomiting with the upper GI usually is that coffee ground emesis. It looks like used coffee grounds, maybe a little bit of like a red tinge to it. I've also seen upper GI bleeds that were very just red chunks. Like I thought it was strawberries on the ground. Versus lower GI, that's when we're going to have melena, so dark, tarry stool, usually abnormal smell. But notice with the bleeding, it's dark, tarry because that blood's been digested. Bright red blood, which we see this, I mean, I know you've ran into it, it's hemorrhoids more often than not. They're sat down,
You can
bright
see it on
red
both
blood.
ends. Yeah.
Yeah. Yeah, so just keep that in mind, right? It's just because there's a little bit of blood, we need to look at it. This is where following up with the vomit, following up with the stool, what can we see? And that's going to make the biggest difference. But yeah, so hematemesis, hemato being blood, and then emesis, vomiting, that's going to be that coffee ground vomit, coffee ground emesis. And then melena, once again, black tarry stool. There's also hematochezia, which I just love that word because it's gross sounding. Hematochezia is bright red blood from the rectum. So that's usually going to be the hemorrhoids. Could potentially be a bleed lower, but that's not really for us to distinguish, outside of maybe seeing some clinical changes.
Yeah, the real important distinction here is to remember that this is a sign or symptom. This is not really a differential. This is a sign or symptom we need to be assessing for the GI bleeding. So there's something else going on that is causing that bleeding, and that's what we need to really be assessing for. And yeah, a lot of it, I think if it's darker red, it's processed and been digested. If it's brighter red, so you got to remember you got your entrance and your exit essentially. If it's this close to the exit, it's going to be bright red. If it's anywhere in the middle, it's going to have gone through and be digested, and it'll be kind of a darker color, and usually very smelly. So, look for those things. In general, bright red blood in the GI system is much less concerning. Varices, which we'll get to, can be bright red, and that can be incredibly life-threatening. But in general, like you were saying, it's probably like hemorrhoids or something if it's coming out of the back end.
Right.
If it's coming out of the mouth, it's hopefully something more minor. But typically if we see that darker tarry stool or vomit, then it's usually been processed and digested and going to be typically a sign of something a little bit worse.
Yeah, for sure. Another thing to consider, this is more of on the school aspect, but when I was in medic school, we ran a scenario, typical scenario with our instructor. We're doing an abdominal pain call, and after the end, a lot of us failed that scenario. And so kind of, we're not supposed to talk about them, so we're not. But then it comes to the end of like, how many of us actually passed this? And the reason came back to, which we all had the same answer, is like, did we take the time in our imagination of this scenario to check the toilet, to look at what the vomit looks like? And none of us did, or none of us that failed did. And so just remember, when you're doing scenarios, if there's a GI bleed, you have information at your disposal if you want to know it, just because it's not fitting that cookie cutter scenario. But you're like, I want to look in the toilet. Is there anything abnormal? Do it, right? It's made up, so it's not like you're actually looking at it for the first place. But two, it could give you information. Worst case, they say, No, there's nothing there. That changes your differential a little bit. But I think it's important, like you were saying too, this is a sign or symptom that we're not treating the cause, we're reacting to what we see. And then remember, these can be life threats. So identification's huge.
Yeah, and life threats, also here we have listed like pallor, tachycardia, hypotension, so just signs of shock. So this could be leading to a hypovolemic shock, and that's what we really need to be looking for these patients, regardless of what the blood looks like or whatever that we're seeing. Like, what is the overall condition of this patient? Are they showing signs and symptoms of shock? Then it's very concerning for us. And we really need to, well, more than anything, we need to get to the hospital because we're not going to open them up to perform surgery, whatever it is. So we need to recognize there's GI bleeding and they are symptomatic and shocky. Let's go real quick to the hospital. Let the people who make lots of money fix them.
Yeah. Yep.
Cool. Moving on. Let's talk a little bit about gastroenteritis. So, on the list of things here, I'm sure everybody listening has encountered gastroenteritis at some point. And again, this is kind of an umbrella term for gastroenteritis, but it's going to be a group of conditions that are going to cause nausea, vomiting, diarrhea. And this is typically something where you take in some food or water that has something bad in it that's going to upset your GI system. So it could be different medications, toxins, something else, but something typically that gets into your GI system doesn't like. And so you get an upset tummy. This is just kind of basically just an upset tummy, right? Like this is food poisoning a lot of the time.
Yeah, you're going to be losing volume from two different directions depending on the severity, and it's going to be unpleasant.
Yeah. You're going to have that nausea, vomiting, diarrhea. It's going to be kind of the really common signs, maybe some abdominal cramping. You might have a fever depending on how significant it is, right? Because it could be just something where, and I'm sure everyone's experienced this, you had something, you went to a restaurant, and there was something that should not have been, it was past expiration. You get home from the restaurant, you and the toilet become best friends for 30 minutes, and then you walk away and everything's done. Or it could be something that you has fevers and like it's more like an infectious process kind of a thing.
Sometimes the toilet's your best friend for a little longer than 32.
That's true. Yeah. Or it could even be the toilet and the bathtub at the same time sometimes, right?
I've seen that one a time or two.
Yeah. So, that's typically going to be gastroenteritis. It's just inflammation, infection within that GI system. It can be bad, especially the extreme ages for populations. So really little, really big, or not really big, really little, really old. Gastroenteritis can cause pretty profound hypovolemia that could, show up as signs and symptoms of shock. So, you have that little guy with nausea, vomiting for a couple days because they are sick. That can be a pretty profound thing for them. So, keep that in mind. We, a little facetious about like upset tummies, but it can be, especially in the elderly population or the very young, this can be a concern because it can just really profoundly dehydrate them.
Right. And then that's where you also can consider outside factors, right? Like, I ate something that's a little off, but I've been out in the sun all day and I've been sweating. So they're already at a low volume. And then, it can just make existing things worse as well. Yeah. So considerations.
Given circumstances too, like, are they, have they been out, like running, or I'm trying to think, there was, RAF guides I know come on this all the time of people like getting in water that hasn't been filtered or treated or whatever, and then people are on the third day in the backcountry and they're having this, and that can be a really concerning thing for them. So make sure you're looking at the story and what's going on there.
Yeah, for sure. Moving in, so we'll move to appendicitis. Moving on, appendicitis. Inflammation of the appendix, small recess of the large intestine, right? So the appendix is kind of the little tail at the base of the ascending colon. At one point, they say it did something for us. At this point, we're not really sure what it does. But yeah, it is a spot where inflammation can start taking over. You can develop things like abscesses, rupturing of the appendix from mass swelling, appendicitis, right? So inflammation of the appendix can start to show up. But this can be another one that sends people to shock. And this is another one where we could run the risk of maybe a couple types of shock, right? So hypovolemia, maybe even some septic shock, depending on how much material is free floating in there. But the big one, lower right abdominal pain, where we're like right lower quadrant. There we go. There's once kind of tests that I've heard people doing, and we learned about it. And I'm not, in my own practice, wasn't a big fan, but the rebound tenderness test, right? So basically what this is someone's complaining of right lower quadrant pain. I walk in and I push in that space and I pull my hand away abruptly. The thought is that's going to cause the appendix to kind of start swinging and, lack of a better description, slapping the inside of the abdominal wall. And it's going to cause some severe pain. They're going to double over. For my care, it was one of those of like, well, I already know that hurts. I'm already thinking appendicitis. Yes, it could be a confirming sign, but I'm not in the business of making people unnecessarily uncomfortable when it's not really going to change my treatment plan.
Yeah, I think in general, initially, a lot of the time, appendicitis is a more general, like umbilicus region kind of radiating out pain. I think this is more if you have that to check that rebound tenderness. If they're like lower right, it hurts for sure, then you already know you don't need to do it. Right. I think this is more of a rule in, rule out of a general abdominal pain.
That's fair. Yeah, that's fair. I mean, use what you have to give yourself the most information, right? Because even though, once again, we're probably not going to do anything to crazy treat for this, especially at the basic scope, it is something to be aware of, and the hospital is going to want to know. Appendicitis also, based on what I've seen, I've never experienced, looks pretty painful. I've also seen it when I had one patient in particular, it's running through my mind, doubled over in pain, and then halfway through transport was like, oh, like gave me that big relief breath. It's like, what's going on, man? It's like, oh, the pain's kind of slowing down. And then I'm checking the pressures, and they're starting to go the wrong direction. It's like, we should probably drive faster because it burst at that point. Yeah. But I have also heard people saying when it burst, they felt the pain. I think that might be a little subjective, but the one I saw was very alarming.
Yeah. And that's the concern, right? Like appendicitis on its own is not life-threatening, really. It's that ruptured appendix that can be really, really concerning and life-threatening.
Yeah.
And you might at that point too, like see some distension, and I believe sometimes you'll even see some bruising, kind of a bruising pattern in that lower right after the rupture of the appendix.
Right. I think it depends on how quick we get to it. Yeah, because there's no bruising on that guy, but it makes sense, right? Because there's now pooling. But big ones, right? And so that right lower quadrant pain, that's also known as McBurney's sign. So if you ever get a question, what's McBurney's sign? Appendicitis, right? McBurney had appendix. But nausea, vomiting, lack of appetite, and that just kind of goes with most GI things. People aren't hungry. If your stomach hurts, you don't want to eat, And when I say stomach, I say that broadly, right? Your abdomen hurts. People don't tend to want to eat. Yeah. So things to consider, right? There's a lot of pieces to this puzzle that you can start flipping and getting ready so that when you finally have enough of them, it's like, okay, this paints the picture well enough for me to get at least a solid guess differential.
Yeah, you'll find most of these things we're going to talk about, nausea, vomiting is going to be a pretty general, broad thing, right? It's finding those hallmarks, like lower right abdominal pain for this one is a hallmark of appendicitis. And so that's what you really need to be looking for to kind of steer you in that direction. If you're just going off like lack of appetite, nausea, vomiting, like that could be gastroenteritis, right? Like that could be no big deal. So you need to kind of have those real specific triggers of like, this is why I think this is what it is.
Yeah. Like kind of have, like you said, trigger words, right? Like and I'm sure this is how my medicine was, is I'd be talking to them, I'd kind of interviewing them, and then they'd say words like, that's a red flag. We got to start, and that's kind of what you're looking for with most things with differentials, but especially the abdomen. Yeah.
Let's move down to bowel obstruction. So this one seems, it's pretty obvious, just bowel obstruction. It makes perfect sense, right? So it could be food, gas, stool, something that's stuck and can't pass through the intestines. So it's going to block everything up. Could happen for all sorts of reasons. It could be like an adhesion from scar tissue, something like that. Could be hernia, could be a tumor. Could be a foreign object, especially with kiddos. Maybe that they swallowed something that's getting stuck in there. Or like dogs is a common one that will swallow, a sock and have bowel obstruction. Yeah. Hopefully your patients aren't swallowing socks or whatever and having bowel obstructions.
Probably not the craziest thing that people have eaten.
Oh, for sure. For sure. But it could be any of those various things. So for this, we might recognize it more like a cramping abdominal pain with these is what's often reported. There may be some vomiting, but no bowel movement because, it's supposed to be one-way traffic. And if it's blocked, you're going to have that traffic jam back and they're going to vomit. So you might see that. There might be some distension as their intestines just kind of start to pack out and fill without being able to empty. And then, like I was saying before, maybe absence of bowel movements or flatulence. They might not be able to, they might feel crampy and like they need to pass their bowels or fart and they can't because
Right.
it's just it just can't pass that blockage.
Right. And that constipation is going to be one of our biggest signs, I think, when you're thinking bowel obstruction. There's also certain demographics to keep in mind. Like I saw these a lot in older folks, but I also saw it in people who were usually IV drug users, like if they're using opiates, or not even necessarily IV, but that's when I saw it most frequently. But people who use and abuse opiates make it so you can't poop. Fun fact. So it's not an uncommon thing for people who are addicted to things like Percocet, even, that they'll sit on the toilet for an hour and not even realize that they haven't pooped in that hour, you know? So that's another one. You can kind of set yourself up for some success, just reading the demographic a little bit.
Yeah, for sure. You want to move on to the next one?
Yeah. So peritonitis. So this is one that I like from a med term perspective. The peritoneal cavity is your abdominal cavity, right? So if we're talking about peritonitis, we're talking about inflammation of the peritoneal cavity. So it's pretty generalized. It's kind of the whole thing hurts, right? It's not like gastroenteritis, which is specific to the stomach and intestines, right? This is that abdominal wall, and all that tissue is starting to get pretty irritated. It does happen from time to time where we have a small amount of fluids between the two layers, keeps them lubricated. That can start to rub and catch, or there's rupturing through that. We can also have foreign material. So this is another thing to think about too, is that blood is an irritant when it's in places it should not be. The example I usually give my students is there's always that one kid in elementary school or middle school, I was one of them, where you get a bloody nose in class and you don't want to go take care of that. So you're like, I got a big brain idea. I'll just swallow this all. And if you threw up, blood's an irritant. If you didn't throw up, you didn't drink enough blood. But things to consider, right? And so if we have something like rupture, or we have something leaking into that bowel, and that blood or that bile or the vomit or the stool or whatever's getting out starts rubbing up against that cavity, it's going to cause some pretty generalized pain. Peritonitis, however, has one of the nastiest progressions that I've ran into, and that's ileus, which is essentially peristalsis. That's the movement, like how the squeezing of your bowels pushes things forward. The peristalsis stops, so your bowel is paralyzed. Well, like Chris was saying, there's an entrance and exit, and it's one-way traffic. This is one where if they can't move forward, they're going to go back, and they will start to vomit stool and fecal material. And it is one of the worst things I've ever been around in my entire life. It's pretty darn close to tied to real dead body, you know? But just keep that in mind, right? This is something where maybe even like a buildup as well. Like, oh, I've been constipated. I've had this generalized pain. I've been nauseous. What's your vomit been like, right? And if they're puking actively when you get there, you're going to know something ain't right. I can't relay well enough how bad this smells. But yeah, there's also can be gas buildup. It's kind of the same thing with like a blocked bowel, right? Things aren't moving forward, so we start to have that gas expanding, so they might look super bloated as well. But severe pain, maybe guarding and rigidity, which guarding is one of those, I've seen a couple of definitions of guarding. It's one of those where you walk up and they're holding their stomach, they're physically guarding it. I've also seen it when you go to touch them and they tense up and they flex because they don't want you to touch it. That's going to be another variation. So guarding can look a little different depending on the circumstance, but either way, if they don't want you to touch their abdomen for whatever reason, guarding.
Yeah.
And the rigidity, right? But fever, nausea, vomiting, and then potentially tachycardia, hypotension, depending on what's leaking in there. If they're in a severe pain, don't be shocked with the tachycardic rate either.
Yeah, and it could be a sepsis thing. Like this will definitely lead to sepsis if untreated. So, just like you're saying, it could be. So the peritoneum has the two sides, right? We have the visceral and the parietal. So the visceral going towards the organs, parietal going away from the organs, and there's that fluid in between. So there could be blood or something getting there, or it could just be in the cavity itself, essentially. Gets trapped in that, because all our organs are kept in like a trash bag, essentially, right? That covers all our abdominal organs, and something bad can get in there. And that can cause all these issues, cause inflammation and all that stuff. So, this could be very, very bad, but usually it takes some time to progress to get to that point.
Right. This is one of those where you're not going to walk up and be like, my tummy hurts. How long? Last 2 hours. Peritonitis. You're not going to do that, right? This is one where they've been going through some discomfort for a while. And then the big one, once again, going back to know your quadrants, if it's generalized If it's everything in their stomach, then it's probably not one isolated organ, at least from our perspective, right? And then that's where maybe peritonitis.
Yeah, maybe it started from an organ. Maybe there's something that ruptured in an organ or something that leaked fluids out into the space, and now the whole space is affected. And so it generally is a pretty severe but more broad. My whole abdomen hurts, not pinpointed to lower right quadrant or upper left quadrant, whatever.
Right. No identifying organ set.
Cool. Let's move on to the next one. We've got acute mesenteric ischemia. So I'm going to use a cheat a little bit here too. It's a condition due to sudden decline in blood flow through the mesenteric vessels, commonly caused by a blood clot or other emboli with a high fatality rate. Patients with an embolic disease typically have a history of the bowel emptying violently followed by severe pain. So essentially, we have the vessels within the in the GI tract, and this is a blockage or something in those vessels, stops blood flow past that. And so to me, I think of it almost like a heart attack, but in the GI system, right? So there's typically like a blood clot or something. And so these patients might have that. And then as that blood flow starts to stops going into the GI system, they will have a massive emptying of the bowels and then severe pain after that. So this typically has pretty significant pain if we see patients like this. And the way it's described in the book and really everywhere else is sudden severe pain that is out of proportion to exam. So you're examining the patient, everything looks normal, but they are just like in excruciating pain, right? That where there's nothing that really like, oh, that's obviously this thing.
Right.
So you might see that. You might have diarrhea, bloody stools, and then advanced cases, hypotension, and then your normal nausea, vomiting as well. So this is one I don't know that I've ever really seen out in the field, or this is one I wasn't even sure to put into this podcast. But it's still good to recognize, just because for when I was reading, there was a study showing 60 to 80% mortality rate for these patients. So it's pretty high.
I mean, we probably have ran these and just not.
Just didn't realize it.
Yeah, there's so many subtle things. I think you brought up a good point. It's kind of like a heart attack, right? Anything that has major vasculature that has a blockage is going to cause problems downstream. If you dam a river, things downriver are not getting what they need. So, I mean, and you can have emboli anywhere. You can get them in vessels in the arms. You can get them in heart, brain, lungs, right? But the mesentery is another big one, especially when you consider its job, right? It breaks down food. It is the digestion process. So it's what gives you nutrition, and that nutrition is transported through vasculature. So if that vasculature is disrupted, you're going to start having some issues with it. It makes sense. And that's pretty hefty vasculature sets down there. And it makes sense too. A lot of organs, like 20 plus feet of small intestine in people, right? So it's one of those, there's got to be a lot of blood vessels to take care of that much organ.
Yeah, it's a whole lot of your body shut down, essentially, because it's not getting blood. So it's not able to do its function. And not only that, but, you know, just like with other tissues, if it starts to lose blood circulation, those tissues just, not only are they not doing their job, but they're actively dying,
right,
and causing, you know, all the acidity buildup and all that happens everywhere else. And so you'll have that issue as well.
Yeah. Cool. Let's move into esophageal varices. I've never seen one of these in person, but I've heard horror stories.
Yeah, I have not, that to my knowledge at least, seen one of these either.
Yeah, it feels like it'd be identifiable. I'll tell the story that's coming to my mind because I think it really identifies these really well. I'll tell it after we talk about it. But so essentially with varices, right? So there's going to be vasculature running around your esophagus, your food tube, right, when you swallow. Well, essentially, we tend to see esophageal varices in people who have liver issues. Tends to tie into drinking because heavy alcohol use does tie to liver failure. But when that liver starts to fail, it's not processing blood forward as well. So it causes a backup effect. And that backup will start moving into those esophageal vasculature, which they'll start dilating and basically dumping blood into the stomach when they rupture, right? So these vessels may rupture, and in more severe cases, and then alcohol, most common cause, like I said, generally is going to be acute. Now, it can be fatal very quickly because of the bleeding. So big one, massive hematemesis. They're going to vomit blood. And this is when I'd assume it's going to be a red blood. It's not going to be a processed blood.
Typically bright red.
Yeah, or like arterial. And then signs of liver disease. So this is one where we might see, you might have kind of I guess even like if you see there's booze bottles out around this person and it's like, are you a drinker? And they just, no, I don't believe you. Right. But it's one of those things like jaundice, if they're getting that yellow, or ascites, which that one we don't talk about much. That's when the liver is pushing fluid out. They basically look super bloated and distended, but it's fluid filled. So they do the tympanic testing on it. If you tap on it, it sounds like a drum. But the story, so this was not mine. Like I said, it was an instructor of mine. When he was working in a different state, his partner intubated a patient that was going unresponsive, and they didn't know he was esophageal varices at the time. Well, he missed his tube, and so he gut tubed him instead of getting it into the trachea. And my teacher said at that moment, like out of the tube was blood just came skyrocketing out, and with such velocity that it hit the ceiling of the ambulance, which checks out as to why hypovolemia is possible.
Yeah.
Right. Like this is something that they're going to bleed a lot very quickly, and we need to get going.
Yeah. Yeah. Essentially, the pressure becomes so that it will start to kind of weep out of the capillaries, and you might have some light bleeding then, but it can rupture. And at that point, I like actual medical emergency. They are, and what's hard is there's nothing for us to do. We can't stem that bleeding.
Yeah.
But like, minutes, because it's such a heavy bleed. And so that's where you might see like really significant bleeding, coughing, vomiting blood, whatever, where you might have those patients that, like you're talking about, all the signs of alcohol abuse or other liver issues, that like coughing up blood here and there, but not super significantly. This is, it's a waterfall of blood when it ruptures.
Yeah. To quote a former instructor of ours, Trevi Fountain, they become the Trevi Fountain cherub spitting blood, just nonstop.
It's a good visual.
Yeah. Oh yeah.
Yeah, I think we covered that one. Pancreatitis is going to be the next one. So it's just an inflammation of the pancreas. It could be caused by a couple different things, including gallstone obstruction, alcohol abuse, or some other diseases as well. And commonly symptoms are going to be worse after eating for these patients. So typically like an epigastric pain. So epigastric being kind of like around the umbilicus, right? That radiates around to the back. So that's one thing we might ask about, that radiation. And if they're saying, yeah, it starts kind of in my front, goes around to the back. Nausea, vomiting, they may have some abdominal distension and tenderness. And then they may have fevers if they become septic due to this inflammation. So I feel like this is one that it's just kind of there. There's not really super identifiable things for this.
For me, there's one guy I ran in particular that I knew was pancreatitis, and I knew from the crew prior that he was likely going to be calling back. The crew prior happened to be my wife too, so she gave me the down and dirty on this. But yeah, when we showed up, he'd been having abdominal pain on and off, but it was getting worse every time he would eat, and then he would drink, and this guy was a drinker. And he was one that I actually, not proud of it, but I had to call him out a little bit. He's like, it only hurts after I drink. It's like, it hurt now? He's like, yeah. It's like, have you drank? Well, no. It's like, okay. And then I looked at his feet, and then he was sliding back a vodka bottle, so I couldn't see it. And it's like, dude, I'm not here to get you in trouble. I'm not going to tell your dad what you're doing. I am going to tell you we need to go to a hospital, but you know the problem, and I know it's one of those things like, I know everyone's got their stuff, so you're not going to convince an alcoholic to stop being an alcoholic in your 15-minute interaction. But it is something where like you can start drawing their attention to. There are very real world effects for what you're choosing to do, and this is one of them. But yeah, I've mostly seen pancreatitis in drinkers has been the big one on my side. Yeah. Yep. Diverticulitis. So there's also diverticulosis, which is like the more chronic variation of this. But diverticulitis, so essentially in your bowels, you have these little flaps, right? They almost look like cilia, but they help keep things moving forward. These can be weak spots at the base of those. And so this is typically a dietary thing you'll see. People eat something that's a little bit harder for their body to process. It gets stuck in those little flaps, and it causes just general irritation. Can cause some pretty severe pain, and then worst case, it can cause fistulation. So the bowel can basically, if there's a loop of bowel, it creates a new shortcut, and then that's the new bowel path, and then everything else past there starts to become ischemic because it's not being used for function. But yeah, this one I've seen mostly. My mom had this of all things, so I've seen it pretty firsthand. Doubled over second with pain, but with her in particular, it was things like seeds, so like strawberries, raspberries, peanuts is another one, and carrots. So things that, it's gonna sound really gross, but the things that you might see again if you look down, after you eat them, those things tend to get stuck. And so that's where we can have these issues. But left lower quadrant pain potential, I would say more in my experience, it's wherever the affected area is. Fever, constipation, or diarrhea depends, and then possible palpable mass, which is actually something I wanted to bring up with blockages. Just because they have a GI block doesn't mean they're not having bowel movements. They can still have very watery diarrhea because now the fluid is going around the blockage. So, and that kind of presentation can start showing up with this as well.
Yeah. Left lower quadrant pain. That's the only one I think on this whole list that has that specific. So that might be something you're thinking about here. And this, a lot of the time, is going to be kind of diet dependent, especially people that don't eat, and none of us do, right? Don't eat very much fiber. It's much more common for those patients. So something to think about there. And I remember the first time I ever heard about this was Brock Lesnar, who was like a UFC fighter. I think he had to like drop out of a fight because he got diverticulitis.
Yeah.
And I think they were saying because he like ate a lot of sunflower seeds or something, and those just kind of create little pockets in there, and those get caught, and then some fecal matter gets caught in there, and it can cause inflammation, and it can get much worse too. Like it can be a life-threatening thing down the line.
Yeah, and it can definitely progress to like a blockage, a full blockage as well, like you were saying.
Yeah. Moving on to the next one, we're going to talk about some AAAs. A AAA is going to be abdominal aortic aneurysm, which is just a real tongue twister. So we'll just call it AAA for
AAA.
If you just think about anatomy and where the aorta goes, it kind of has that arch off of the heart and comes down, and it goes down through the abdomen. And so an aneurysm, we typically think of aneurysms more in the brain. We'll talk about, brain aneurysms a lot, but that's just that weakening of the walls of the vasculature, and it kind of can balloon out. So we can have that happen in our abdomen in the aorta. And so, it's always fun to see students, because we commonly, with our school, will, if we have the availability, we'll like dissect pig hearts and stuff. And I think in most people's minds, like, oh yeah, like the big vasculature is gonna be like the size of a pen or something. Like, no, dude, it's like a garden hose, right?
Yeah.
It's big, and so that's gonna be the aorta coming down. You have a big old garden hose filled with blood coming down, and so for whatever reason, that wall gets weak, and we get a bulge, and that wall essentially is going to be an aortic aneurysm. So really common for patients with these to have like a sharp tearing pain in the abdomen, kind of radiating through to the back. It's typically the hallmark of what we're going to see for these patients. And then you might have a palpable mass. So you might have a mass in the abdomen that you can feel, and it usually will be pulsatile. So you can feel the pulse in the abdomen where that bulge is coming out. So these patients you need to be incredibly gentle with, because those can rupture. And if they rupture in the aorta, like I don't think I've seen a ruptured AAA, but I have been on at least one patient I distinctly know had a ruptured an aortic arch. They had the rupture up there. And it was like 10 minutes, they were dead just because they bled out essentially internally. Right. So we need to be incredibly cautious and gentle with these patients. If we suspect it, they're complaining about that sharp, sudden onset tearing pain, gently palpate their abdomen, have them sit gently. Everything needs to be gentle because we don't want to cause that to rupture.
Right.
If it does rupture, then we're going to have pretty fast shock symptoms. One thing that people can get a bit confused about is the abnormal vital signs, one side to the other. You typically won't have that with a AAA. It's too low in the circulation, essentially. That would be up higher, more off the aortic arch. So if you have that rupture up there, or that tearing, then you'll have those abnormal pulses, where in the abdomen you're typically not going to have that. What we'll see is, I believe it's the left arm has a good strong pulse, but the right arm has no pulse, and the blood pressure will be significantly lower than the left arm.
Right. And yeah, you might even have differing blood pressures, like you were saying. I think the easiest way to describe what an aneurysm looks like is imagine a basketball where the seam has split and the bladder is coming through, right? Like the basketball, when it's all held together, is pretty sturdy, but when there's that one weak spot, you have that balloon pushing its way through, and that's going to be that aneurysm. Have you ever palped a AAA before?
I have not. I've never recognized one in the field.
Oh, it was awful.
Oh, really?
Yeah. It's abdominal pain, pale, cool, looked the whole thing, and then I palped it, and it was one of those just like, that's got a pulse. And I looked at my partner, I was like, do you want to feel this real quick? And which, we've been medics long enough at that point where she's like, okay. And then I watched as she palped in her eyes just... and yeah, we drove pretty fast. That person ended up surviving, which was cool. But yeah, usually if these rupture, it's a race against time. You have not a lot of time, and your cardiac arrest management ain't going to do anything because you're trying to work through broken pipes.
Yeah, all the blood you're trying to push through is just in the abdominal cavity.
Yeah,
so
that's just
you're
where
not doing very much.
Yeah. Cool. Yeah, so ulcers, moving down. I always think of Dumb and Dumber with ulcers. But ulcers, you have a breakdown of the layer, your stomach, and the duodenum or duodenum, however you want to say it, that protects from the high level of acidity. So yeah, inside of our stomach, we have a mucus lining. The whole point of that is to stop the acid from just kissing the inside of your stomach organ itself, because obviously acid and tissue don't blend very well.
Not good friends.
No. So when we have ulcers, we basically burn through that mucus lining. So now we have that acid directly touching the organ, which can cause variation of effects. I'm imagining with really bad severity and like untreated, you could progress to the rupturing of the stomach at that point. But it's going to be like one of those things we might see bleeding start to pop up. That's why, fun facts, if you're giving aspirin, that's one of those things why you ask about ulcers, right? Because there's a chance that they're bleeding, and we can stop the chance or their ability to clot from working effectively. Now, peptic ulcers generally due to infection from that's a big one, Helicobacter pylori bacteria. But other causes can include chronic use of NSAIDs, stress, alcohol, smoking, all potential, right? Anytime you're messing with the very delicate biome of your stomach and you're introducing things that should not be there, that's going to be problematic. The reason I think of Dumb and Dumber, though, with ulcers is because after they eat, there's going to be burning, right? They're going to have pretty severe pain because the acid is stemming up, right? So don't give them a bunch of peppers. But pain is usually in the upper abdomen. Abdomen.
Yeah, this is a tricky one with the words.
Words today, yeah. But yeah, usually it's going to be in the upper abdomen. Think about where the stomach lives. It kind of lives not quite down as low as the belly button, but in between the upper two quadrants there. And then heartburn, nausea, vomiting, and then in severe cases, GI bleeding can start showing up. And then you can have ulcers starting to develop, like I said, in the duodenum. So that's going to be like the first few sections of the small intestine. But anything that's touching acid, there's a potential for them.
And this is something that's more common in the older population. From what I was reading, mostly due to their more common use of NSAIDs and stuff, which just, I think, affects the acidity and creates more acidity, which is why, like, smoking causes this. It just affects the pH balance in the stomach and causes it to go more acidic. And so that's why it's going to affect those populations a little more specifically and more often.
Makes sense.
Next, kind of a little bit in the same line, is going to be GERD, or gastroesophageal reflux disease, or heartburn, essentially, is what this is going to be. So the acid is just kind of backing up and going up into the esophagus, and it doesn't feel very good. And so patients might complain about that. So we're typically going to have that heartburn pain, which is kind of a burning sensation, kind of midline through, kind of up into the throat. Can cause regurgitation, so maybe some vomiting as well. You might have a chronic cough or hoarseness with this if it's a constant thing that is just affecting, all those structures. With just this higher level of acid, can kind of, hurt the vocal cords and all that as it's kind of being washed in stomach acid
coming up.
So this is one thing that we need to be concerned about, because this can kind of look, or a heart attack or GERD can kind of mimic a heart attack for some patients. So this is one of those things that really getting that good history can be helpful with, like, what have you eaten? I get GERD if I overeat, especially if it's something acidic. Like, a big one for me is, like, tomato products like pizza or pasta, because those are so acidic. It really will spike GERD for me if I eat too much pizza. So, which I of course never do.
Yeah,
Very
so
healthy.
sad.
So healthy. You shut up, Sabrina. But so that for me is like my big thing. I overeat, the stomach gets over full, and then it just gets acidic, and it starts to push that up. This is commonly relieved by patients laying on their left side. And so you might hear patients say it feels a little bit better, or you personally, if you get heartburn, if you lay on your left side, and it's just based off where the stomach sits, it's more left. And so it's keeping the stomach below the line of the esophagus is why it's more comfortable for patients on the left side. This is not going to be something that's really life-threatening. May cause some issues like we talked about long-term of always having that acid kind of coming up, but not really a life threat, not really much for us to do. Don't do this. This is off-label, but I have heard about paramedics drinking sodium bicarb when they're having it. It's just, it's just some sodium.
It makes sense.
It's just a base that kind of equalizes out in the stomach a little bit. So I may have seen my partner drink some sodium bicarb to help some GERD before.
Did it help?
Apparently. It was not the first time, not the last time this person has done this. So apparently it helps them out. But yeah, pretty basic one, just heartburn. If you remember, GERD is just heartburn.
Yeah. And I've seen it too with like people who have severe GERD. They'll have maybe some sores starting to show up in their throat, and that's just kind of the same vein. It's the fumes, and they're probably going to burp. That like acidic burp happens pretty commonly.
It's not great.
No, not fun. Getting old's not fun. That's been a fun development.
I don't know what that's like. I'm young.
Yeah, young, and no wonder. I was wondering how you're such a pretty 25-year-old man.
Thank you.
Gallstones. So the gallbladder. I always imagine it as the little fish that lives under the shark, right? The gallbladder lives under your liver right there. But its whole job is to hold bile. It's kind of like your storage for bile, and it injects that into the stomach to help with digestion, as well as down into the small intestine to help with the digestion process, the enzymes in it. But gallstones can cause blockages. So basically, because your liver helps to process out fatty things, a lot of these gallstones tend to be fatty deposits, essentially. And the gallbladder's not big, so it doesn't take a whole lot of these for them to become problematic. Usually when you see them become a real issue is they're stuffed full of these bad boys, which is why a lot of folks, usually older folks, will get the gallbladder removed. But yeah, so in severe cases, they can actually cause the gallbladder to rupture. Now, most commonly found in women, older adults, obese people, people of Scandinavian descent, Native American or Hispanic descent, which that's interesting. I didn't know that. I wonder if that's probably just dietary potential.
I don't know. This is what the internet told me.
Oh, well, that's got to be true. Though the way I remembered gallstones or gallbladder issues is the 4 Fs. And it's just, they're pretty crude, but fat, 40, female, fatty foods. If they fall under that demographic and they're having upper right pain, that's probably going to show up. And typically that pain will start to flare up once they eat, because now the gallbladder needs to start working and doing its
typically
stuff.
Fatty meals after they do fatty meal.
Yeah, the typical scenario you'll get is like you go up to a patient with right upper quadrant pain who just ate a double bacon cheeseburger, right? Like that's the typical lead in. But right upper quadrant pain, possibly referred to the right upper back, shoulder, or flank. Pain after fatty meals, nausea, vomiting, here we are again. Might have indigestion, bloating, gas, or even jaundice, depending on how backed up those bile ducts are. So it's one of those things that it does pop up fairly commonly. This is not an uncommon thing, but it's one of those that I've heard diet is a huge component to this.
Yeah, for sure. Yeah, I feel like the only times I've seen this have been exactly what you said, right? Like it's just that patient demographic is kind of it points directly to it. And every time it's been like exactly what you would expect of like, oh yeah, I had whatever, something with like super high fat content. It's like, oh, well, there you go. And it kind of makes sense.
Yep. And then this is another one that can have Murphy's sign. So Murphy's sign, not to be confused with McBurney's sign, but Murphy's sign elicited in patients with acute cholecystitis. So cholecyst is your gallbladder itis inflammation. So you'll have similar presentations with cholecystitis as well as gallstones. We're obviously not going to be the root cause identifiers, right? That's something they're going to need imaging. But to identify, you can ask the patient to take and hold a deep breath while palpating the right subcostal area, so just underneath that rib cage where the liver lives. If pain occurs on inspiration, then when the inflamed gallbladder comes into contact with the hand, that's Murphy's sign. So it's a positive finding.
Yeah, so just put your hand under there, palpate gently, have them take a big, deep breath. And as it expands, they might get pain as they start to put some pressure on it. So that's going to be a positive Murphy sign.
You're basically just poking it.
Mm-hmm.
Yeah.
Yeah. That kind of covers all we had here. We don't have any treatments, but the best treatment for any of these things is to subscribe to the channel. So you should do that if you haven't done it already. Yeah.
Slick.
But yeah, so, this is one of those things, like we said before, like it's so convoluted sometimes because there's just so much in the abdomen that all kind of looks the same and feels the same as far as what the signs and symptoms can be. So, if to me, if there's any takeaway, find a couple of those trigger words, right? Like upper right quadrant, Murphy sign, what McBurney sign, whatever it is, to kind of have in the back of your head for when you have somebody with an upset tummy or some tummy pain of like, where's that tummy pain at? What does that mean? And, really big to identify, like, is this GERD or is this a ruptured esophageal varice, right? Like, is this going to kill them quickly and it's a high medical emergency, or is this something that's a little bit less concerning? As uncomfortable as it can be for the patient, what's our risk of life and death for these kind of patients?
Right. Unfortunately, pain doesn't often kill people. Hardly ever, in fact.
Yeah.
And I think the biggest takeaway when it comes to any differentials with the abdomen is identify life threat or not, right? Which is looking past just what's hurting them. Now we got to identify signs of shock. That's going to be your biggest takeaway, because realistically, we don't have the means to see what's really going on, so we don't fix the problem because we can't.
Yeah.
Yeah.
Well, cool. Hopefully, everyone listening and watching, hopefully this gives you some good guidance on some of the mysteries of the abdomen and, for assessment for those things. We have another similar one on chest pain for differentials. So make sure you're getting your differentials down. If you're a student, this is really what it's all about, right? Like, that is what assessment is finding the chief complaint and then kind of making your list of differentials that you need to include or exclude based off your findings, and starting to ask those questions and doing those things we talked about at the top of the podcast for your ask your PQST, your samples, your all that stuff. So hopefully this can kind of guide everyone down a path to be a little more comfortable and confident with that.
Yeah. I'd say also takeaway is don't just assume that these are benign things every single time.
Oh, yeah.
These are underdiagnosed and undertreated fairly frequently. Do your patient and yourself a favor and just be thorough. End of the day, the doctors are going to make the final calls, but you still can do your job as well as you can, even if it's something that feels benign and sometimes silly.
Yep, for sure.
Cool.
Thanks, brother.
You're welcome. Thank you.
Yeah. Thanks for watching. Thanks for listening. Hit subscribe if you didn't already with my great treatment plan of subscribing to the channel.
Yeah.
Tell all your friends, like, thumbs up, all that stuff, and we'll talk to you guys soon.
Catch you next time.